Thank you very much. First of all, thank you very much for having me in this wonderful conference of 30 years anniversary of CalCELS. And also, it is a great honor to share my idea in front of two giants of MIS, two Professor Kims. And I was asked to talk on 3 decades of MIS lessons and the road ahead. It's not, okay. No disclosures. My first laparoscopic colectomy was in 1994 in very small communal hospital. It's mostly right hemicolectomy, APR and lower anterior section. While in Western countries, already they started in the 1990s, some of pioneers. But I must say that the biggest event, what happened to Korea in 2000 was the Korean laparoscopic colorectal surgery study group. We organized this meeting at the end of 2000 in Samsung Medical Center. And you see the chairman who served for a long time as a chairman of this study group to lead our community. And we started with a small group, only 12 members started. And just 3 years later, it becomes larger. It's 42 among 27 hospitals are involved. And every other month, we had a conference and we had the live surgeries. We tried to develop what is the better way to serve the patients with minimally invasive surgery. And another 3 years later, explosively increased in terms of number of the members, more than 180. And these efforts actually made the situation we have in Korea now. As a result, we started with 2006, only 27% of penetration of laparoscopy for colorectal cancer treatment. So recently, 2018 is more than 28%. We treat the patient with minimally invasive, mainly laparoscopic approaches. More recently, in nationwide data show that 83% of colon cancer is treated either by laparoscopy or robots. So for colon cancer, the robot is limited to for the application is only 6.5% in nationwide. But in rectal cancer, it is gradually increasing. It's up to 28% of total the patients who have rectal cancers. And altogether with laparoscopy is more than 90%, we treat rectal cancer by minimally invasive approaches. Only 10% of the patients, we do open surgery for rectal cancer. This is the situation we have in Korea. And as you all know that there are many previous RCTs already show that the short-term outcomes are better and the long-term outcomes are equivalent to open surgery, is well confirmed. It took a little bit longer in rectal cancer, but still we have similar results. Short-term outcome is better and the long-term outcomes equivalent to open surgery. So among these RCTs, I'm very proud of our Korean trials, which is done by so Rational Brothers, they showed extremely good results even after chemoradiations. It's unparalleled to any data from any other RCTs. So they showed that laparoscopic surgery demonstrated at least equal, even better, over open surgery for advanced rectal cancer, even after chemoradiations. So rectal cancer, short-term benefits confirmed. Survival is also equivalent or slightly better. These results are well proven. This is my personal experience on the primary colorectal cancer since last 30 years. Total cases are 12,000. The laparoscopic mainly is around 70% because of in the previous time, when I was very young, it was not permitted to do laparoscopic surgery for colorectal cancers. We had some conflict, but finally we made more than almost 80-90% of the patient we treat laparoscopy or robotic cases. And this is the learning curve we resulted previous time, but I think it's a learning curve for minimally invasive surgery reflects not only skill acquisition, but also it is just because of the better understanding of surgery itself, because surgery is thinking process, is a brain game, it's not the physical skills. And we also published the long-term outcomes since a long time ago to compare laparoscopy versus open surgery in rectal cancers. It showed there are better recovery and equivalent long-term outcomes in terms of oncologic outcomes and disease-free and overall survival as well. And the intersphincter resection is one of the hardest indication for colorectal surgeons. And we compared the same things, open versus laparoscopy. We found the same thing, same findings. It's a better recovery and similar oncologic outcomes compared to the open surgery. And with the accumulation of our experience, we tried to extend our indication to more complex, more extensive disease. For example, obstructing colon cancers and multi-organ resections and cytoreductive surgery or intraperitoneal chemotherapy or some complex lymph node dissections. This is one of the example of the obstructing colon cancers. We compared stent and laparoscopy group versus open lavage group for the obstructing colon cancers. As you can see that the early recovery, it happens to the stent and laparoscopy surgery group compared to the open surgery group. And also the long-term outcome is slightly better, but statistically not significant between the two groups. They showed only perineural invasion was higher in a stent group, we can expect, but the long-term results showed there is no difference in terms of recurrences. And also laparoscopic lateral pelvic node dissection, not a great number of patients we tried and we reported successful results. And also para-aortic lymph node dissection we tried. And what we found is when the patient showed limited number of metastases along the para-aortic area, it showed great, excellent results only even after application of the laparoscopic surgery compared to the open surgery group. And for the selective patient, when the patient had their limited or confined peritoneal metastasis, we applied laparoscopic surgery for these patients. And what we found is the survival is not related, is related disease extent and completeness of surgery, but not related with approach of procedures, which means laparoscopic surgery can be safely applied when you select a patient with their confined peritoneal metastasis. So on the other hand, we try to make a less and less invasive surgery using single port or natural orifice specimen extraction. And we reported that even right hemicolectomy for their female patients, we removed the specimens through the vagina. We found that the better recovery, and especially the cosmesis and pain score is much better in natural orifice specimen extraction group compared to conventional laparoscopic surgery group. And with long-term follow-up, also operation time is longer, less pain, and early recovery of the bowel movement and better cosmesis with similar morbidity and similar survival. The end of 2007, we purchased a robot in our institute. And we studied a very small randomized clinical trial for right hemicolectomies. And what we found is it is feasible and safe, but considering the higher cost of the robot, we found that there is no significant clinical benefits to justify the great cost for the right hemicolectomy. So since these trials, it is not a routine indication for me, personally, not for everybody, to use the robot for colon cancers. However, the rectal cancer is one of the best indications for the robotic approaches. And we published that short-term outcomes are at least equivalent, is better in the robotic approach compared to the laparoscopic surgery. And we did a multi-center studies, Korean laparoscopic colorectal surgery study group, one of the studies we did. And what we found is the robotic approach is exactly the same as the laparoscopic surgery group in terms of local recurrences and overall survivors, disease-free survivors. And this is our institutional results recently published. That we found that generally it's long-term oncological outcomes comparing the laparoscopic versus robot showed similar. But in selected patient with middle rectal cancer with T3T4, even after chemoradiation, which means not very well responded to chemoradiation. These patients, robot approach is beneficial to this subset of this patient. These are the results. Robot is significantly better in terms of relapse-free and distant metastasis-free survivors. And also lateral pelvic node dissection, when we apply the robotic approach compared to laparoscopic surgery, we found that the favorable long-term overall survival compared to the laparoscopic surgery group. As you know, that the first RCTs for the rectal cancer is done by LOLA trial, which is pan-world, but it's mainly led by UK. Unfortunately, they could not find any statistical advantages in reducing the conversion rate. But recent publication, which was done by Chinese group, they showed in almost all variables, they showed better outcomes in the robotic group compared to the laparoscopic surgery group. I don't know, this is not reproducible for any other countries, but only China showed excellent results. This is our own data. We published 2023. Our randomized clinical trial also showed there is no differences between the robot versus laparoscopic surgery. Our main goal was to compare, to enhance the completeness of the TME, but we could not find significant differences between the two groups. However, in low rectal cancers, we found that circumferential resection margin is slightly better in the robotic group compared to the laparoscopic surgery group. But in mobility and mortality, it is exactly identical between the two groups, and quality of life, and the bowel movement, and the sexual function for male patient, and the voiding functions are exactly same in between the two groups. And then what is the future surgery? Maybe if we can see better, if we know better, maybe we can do better. This is my idea of surgery 3 components. What is the vision methods? You know, the display is extremely important for minimally invasive surgery. We need a better quality of visions, and there are many ways to increase vision which was not visible in the before, but now we can use the fluorescence for blood supply or for lymph node mapping. And also we can use 3D reconstruction of the CT scan or MRI to navigate some target organs during the operations. And this is a short video. We can use both of these image guidance of fluorescence and also 3D reconstruction of these techniques for the lateral pelvic node dissection. And also, some scientists, some surgeons are trying to find a way, something invisible, to see the invisibles, even tumor emboli circulating in the lymphatic channel or in the vascular circulations. This is one of the studies was done by one of my colleagues in Hejin Kim. She studied the cancer-specific fluorescence. As you can see here, when the lymph nodes are metastatic, you can see the yellow color of fluorescence, the wild greenish color, which is normal ICG, showed green colors. We can differentiate this metastatic or non-metastatic lymph nodes. We published several papers on the fluorescence. And what is the way to know better? Probably the AI is the answer. So now there are many studies are ongoing, especially this is one of the example by one of my friends, Masaki Ito, mainly by image recognition of the anatomies, and they used the navigations during the surgery to guide some of beginners or naives to make enhance the quality of surgery. So how can we do better? Probably we can use the robots, not by surgeon's hand anymore. We have many robotic systems, but still it is not enough to make autonomous real robotic surgeries. But just I would like to share my idea on Da Vinci SP system, which is less invasive than the multi-port robotic surgeries. So this is my own experience. It's total robotic SP. I did till last year 273 cases, mainly low anterior section and ISR and anterior section. But some of APR, some of colon cancers, and some of other indications. And especially, I would like to share these results for combined resection because of, thanks to the multiple quadrant coverage by SP system, we can do the multi-organ resection with any other related colorectal cancers. In 31 cases, we did hepatectomy, we did gastrectomy, we did some other organ resections combined with colorectal resections. And so we have two different, roughly saying that the two different type of robots, multi-ports, which is Da Vinci or other companies, but the SP system is different. So for application of SP, the entry port is extremely important. The umbilicus can be the main entry port for universal use, but it has some drawbacks in terms of risk of incisional hernia is slightly higher than any other area. But right lower quadrant is strongly suggested to left colon cancer or rectal cancers, as we can use this incision for ileostomy as for specimen extraction. As multi-purpose right lower quadrant approach is better. And suprapubic is you can cover all of the colon surgeries. It doesn't matter, it's right, left, transverse, you can approach all the colon. Entire colon you can use suprapubic approaches. And the one thing is very important and very useful is a stomach-site entry port. For example, APR or Hartmann reversal. You can use this area specifically by the SP system to cover the APR or Hartmann reversal. So we have two options, multi-port and single port. Many considerations we have to do is the tumor characteristics, patient characteristics, or technology which is available now. So I suggested this diagram when you choose which platform is optimal for your patients. When the patient showed very aggressive tumor, probably I suggest multi-port, which is XI or Da Vinci 5. But when you plan to the nose, natural orifice specimen extraction, we don't need no additional incisions. We prepare XI system or Da Vinci 5. But when you use the robotic system for APR or ISR, which needs ileostomies, and I prepare SP system because I can use this entry port as an entry port and also specimen extraction and also ileostomies. So nowadays we are around in the middle of this graph, probably in the near future. So full autonomy is powered by AI and the robot can be achieved. So real future is actually coming to colorectal cancer management, non-operative management. After total neoadjuvant treatment and immunotherapy, we need that already more than 1/3 of patients can avoid unnecessary surgery after neoadjuvant treatment. And the tailored treatment based on molecular characteristics, microscopic imagings, and also clinical phenomenon only analyzed by AI can give us which is the most optimal treatment for this individual patient. Also, the liquid biopsy is important tool to screen and to surveillance for the cancer patient. So as a futurist, one of the futurists already showed that the singularity will come to us by 2045. Probably we have 20 years more. I don't care because I will retire very soon. So probably in near future, perfect TME can be done within a minutes, powered by AI and the image-based and the robots. So surgery is my dream, which I have chased for a long time, for more than 30 years. And I have lived with this dream. Even after I leave this academic position, maybe I will miss for a long time. Thank you very much for your kind attention.
Good evening, ladies and gentlemen. It is a great honor to speak today on Korean MIS trials in reading global standards and representing our society KSERS cases. No COI in this presentation. Over the past 3 decades, MIS has evolved. This progress has been mainly driven by the laparoscopic techniques, also enabling technologies such as stapling device, energy platform, or articulating instruments. More recently, we have entered a new phase with the emergence of the multiple robotic platforms, or as well as AI-driven navigation system or AR/VR technologies. And we are witnessing a continuous expansion of what is technically possible and on now. But this rapid evolution raises an important question: then, are we evolving just in technique or also in standards? Because without evidence, it can't become a standard. And this is a very important point for especially cancer, MIS cancer surgery. In the early days of MIS, adoption was largely driven by individual experience or institutional preference. Decisions depended on by the surgeon rather than the level of evidence. At that time, the key question was very simple: is MIS feasible? But today, we are in a different era, and the evidence-driven era, and so the question should be changed and already have been changed. Is MIS oncologically safe, reproducible, and generalizable? We have to answer these 3 questions. So then why in Korea? First, we have a high surgical volume. And second, we have a strong technical consistency and standardization. And finally, a well-established culture of collaboration among participants and several institutions. So Korea was uniquely positioned to generate high-level evidence through the multi-center trials. Especially the upper GI and the colorectal surgeons groups have spearheaded these efforts. One of the key groups representing this trial is the CLASS group, and the CLASS have played a pivotal role in establishing global standards in the field of the gastric cancer surgery. In fact, their results are now reflected in the Korean gastric cancer treatment guideline, as well as Japanese or other international guidelines. So let me walk you through the CRAS trials at first. And this is the full landscape of the CRAS trials, and from early disease to advanced stage, and from technical innovation to functional outcomes. The CRAS group has systematically built the evidence of MIS. And then let me highlight a few key studies. The first milestone is the CRAS-1 trial led by Professor Hyung-Ho Kim, a current chair in this session. And this randomized trial compared laparoscopic and open distal gastrectomy in clinical stage 1 gastric cancer. This trial consists of the very systematic contents, and from the feasibility test, and to surgical safety, and finally long-term oncologic outcomes. Let me briefly show the early evidence from CRAS-1 trial. In a large retrospective cohort of about 3,000 patients, survival outcomes were comparable between laparoscopic and open distal gastrectomy. Even after adjusting for stage and surgical approach by the surgeons, this result remained still consistent. So from the very beginning, the laparoscopic distal gastrectomy showed equivalent long-term oncologic outcomes. Next, the interim analysis of this trial addressed surgical safety. There was no significant difference in overall complication between the two groups. Also, serious complication or mortality was comparable between two approaches. In other words, laparoscopic surgery was just as safe as open surgery. In the full cohort analysis, short-term outcomes actually favored laparoscopic surgery, highlighted in the wound complication. But as you know, the safety alone is not enough to prove the some safety itself. The final analysis showed the equivalent to 5-year overall survival and cancer-specific survival between the two groups. As you see, the results the survival outcomes were similar and no difference between the two groups. And these results established laparoscopic distal gastrectomy as an oncologically safe alternative to open surgery in stage 1 gastric cancer. Importantly, these findings changed the clinical guidelines. Now, with a high level of evidence, laparoscopic distal gastrectomy is strongly recommended for clinical T1 gastric cancer. And this is a good example of how evidence becomes a standard. Then, once safety was established in early cancer, the next question was naturally clear. Then, can MIS be applied to advanced disease? This led to the CRAS-2 trial led by Professor Sang-Woo Khan, the previous president of our society. And this study compared the laparoscopic and open surgery in locally advanced gastric cancer. Importantly, it introduced the concept of the surgical quality control and ensuring standardized T2 lymph node dissection across the centers and among all surgeons. Because without surgical quality control, surgical trials cannot produce reliable and reproducible evidence. A key feature of CRAS-2 trial was surgical quality control, and participating surgeons were required to submit several unedited videos in each open and laparoscopic surgery. It was rigorously reviewed by expert peers under strict qualification criteria. And this ensured that T2 lymph node dissection was performed in a standardized and reproducible manner. And this is a major milestone in this trial, showing that high-quality surgical trials are possible only with strict quality control. And this is why the results of the CRAS-2 trial are credible. Importantly, this trial results show that laparoscopic surgery was not only equivalent, safe, in advanced gastric cancer. Also, it showed the advantages. Early complication represented by the intra-abdominal fluid collection or bleeding was lower, and the long-term outcomes such as intestinal obstruction favored laparoscopic surgery in some aspects. This suggests that MIS can be extended beyond the early disease, but ultimately the key question is remained: what about oncological outcomes? The Class 2 trial demonstrates non-inferior survival outcomes for relapse-free survival for laparoscopic surgery compared to open distal gastrectomy. And this finding was consistent across subgroups, and long-term follow also confirmed comparable overall survival. And finally, these results support laparoscopic gastrectomy as a standard treatment option for locally advanced gastric cancer, followed by early gastric cancer. This is how MIS moved from early to advanced disease. These findings were again incorporated in the clinical guideline, and currently with high-level evidence, laparoscopic distal gastrectomy is now strongly recommended for locally advanced gastric cancer. Then evidence becomes stronger through the collaboration, and Class 2 data were pooled with CRAS-1 from the RCT from China were created. This pool created a large multinational data set from 2 randomized trials and consisting of over 1,800 patients' data. And from this pooled analysis, an important finding emerged. In the T4 group, as you see, the relapse-free survival was slightly worse in laparoscopic group, and also overall survival tend to be lower, show a similar trend. So this is important because MIS cannot be perfect, but this is exactly the strength of the Korean trials, because we didn't just prove success. We also we identify and define the limitation of MIS. As surgical and oncological safety was proved in laparoscopic in the field of the distal gastrectomy, and next challenge is the application of laparoscopic surgery in total gastrectomy. It's a high challenge in gastric cancer surgeon, and the Class 6 trial compared the laparoscopic and open total gastrectomy in locally advanced gastric cancer. And this trial is led by Professor Hyung-Ho, current chairman of board of directors in our society. And this study also adopted the surgeon qualification for participation, and a total of the 28 surgeons from 16 institutions were qualified to participate. Patient enrollment has been completed, and we are awaiting the short-term and the oncology results. Taken together, these trials have provided high-level evidence of MIS in the field of the gastric cancer surgery, and these findings have been incorporated in the Korean gastric cancer treatment guideline as well the international guidelines. So now, strongly laparoscopic distal gastrectomy is strongly recommended for any kind of the gastric cancer, and the in the field of the total gastrectomy, Class 6 trial will provide strong evidence, robust evidence for that. And so Nature Reviews mentioned our Class trial because it is a good example of the surgical trials. So, but Korean trials did not stop in gastric cancer, and they expanded the MIS to another field of the GI surgery, colorectal surgery. And next representative study is a Korean trial comparing laparoscopic and open surgery in middle or rectal cancer. And once again, this was tested through randomized trials. The Korean trial evaluated the laparoscopic versus open surgery for rectal cancer after neoadjuvant chemoradiation. Although operation time was longer in laparoscopic group, however, laparoscopic surgery showed clear short-term advantages. Blood loss was lower and the recovery was faster. So even in rectal cancer, MIS proved to be not only safe, but provide advantage in the short term. But again, short-term benefit is not enough. The key finding was oncologic equivalence, and disease-free survival was comparable between the two groups, and this was consistent also across the pathology YP stages, and there were also no difference in overall survival and local recurrence rate. So, even in the locally advanced rectal cancer, MIS provides equivalent oncologic outcomes we came to know. And long-term follow-up results confirm the message. At 10 years, there was no difference in overall survival and disease-free survival and local recurrence all across the tumor stage. This firmly established the long-term oncologic safety of MIS in rectal cancer. And this is how MIS became a standard across all gastrointestinal surgery. The impact of the Korean trial extends to the international guideline. This trial did not remain just as an academic publication. They changed the clinical guideline from Korean one to globally. This is the true value of the surgical trials we are pursuing. Beyond generating high-level evidence through randomized trials, and Korean surgical studies have also focused on improving surgical quality, patient quality of life, and reducing surgical stress. And our previous president and chairman are spearheading in these trials, and they are not only about the evidence, they are about better surgery and better life for our patients. And this is where next generation of MIS is heading. Although generating high-level evidence through randomized trial is very challenging, efforts continue across other fields, including hepatobiliary pancreas and endocrine surgery, and we expect these ongoing trials to further shape global standards in the near future. Let me close with this message. MIS has evolved rapidly, and through well-designed randomized trials, it has become a global standard in the field of gastrointestinal surgery. So we have to, this is the time we have to answer the previous three questions. Can MIS be oncologically safe, reproducible, and generalizable? The answer is I can say yes, and Korean trials have played a key role in making that possible. We didn't just study MIS, we made it standard. Looking ahead, cases will continue to read, made it the next era of the surgical innovation, just from simple MIS to intelligent or data-driven surgery. Thank you for your kind attention.
Development of an AI-integrated extended reality surgical support system using a video pass-through head-mount display, enhancing spatial coherence in robotic hepatic and pancreatic surgery. Robotic hepato-pancreatic biliary surgery is performed through a remote console interface, where surgeons depend entirely on endoscopic visualization and indirect spatial cues. In this environment, even subtle inconsistencies between preoperative anatomical understanding and intraoperative findings may compromise surgical precision and safety. This challenge is particularly pronounced during high-risk procedure phases, including determination of hepatic reconstruction phase, hepatic transection frames, identification of segmental and subsegmental Grisonian pedicles, and handling of SMV branches during pancreatic surgery.
Nowadays, the current single modality imaging for preoperative surgical planning and intraoperative surgical guidance using CT and MRI has certain limitations in certainly identifying the actual anatomy, which is crucial for surgeons to make correct intra-procedural decisions. So why do we scan and diagnose on a 2D paper or display when the patient body is 3D? So the GPS car navigation for car driving reduces the burden of memorizing maps and improves time efficiency. So the navigation systems and AI laid the foundation for self-driving technology.
Advancements in laparoscopic and robotic hepatopancreatobiliary surgery are heavily reliant on technological evolution. Our team has developed a state-of-the-art cloud-based holographic surgical guiding and telenavigation system. This system enhances anatomical visualization, surgical planning, and intraoperative guidance, particularly focusing on the effectiveness of optical and video see-through head-mounted displays in surgical navigation. We developed an extended reality (XR) technology-based surgical navigation and training system. Today, the majority of medical imaging is presented in 2 dimensions. As amazing as CT and MRI scans are, their display in 2D requires physicians to use their imaginations to mentally stitch together paper-thin images and pictures of how they fit together in a 3D human being. Current single-modality imaging for preoperative surgical planning and intraoperative surgical guidance using CT and MRI has certain limitations in clearly identifying the actual anatomy, which is crucial for surgeons to make correct intraprocedural decisions. Image-guided simulation and navigation in surgery are often used to assist in understanding the complex 3D anatomical structure and pathology in individual patients. However, 3D reconstructed images from CT or MRI have only been presented on a flat display, which cannot accurately represent the actual spatial location of the organs, lesions, and surgical instruments. To improve the gap between the surgeon's skill level and spatial awareness, we developed a surgical guidance system using extended reality, XR/VR virtual reality, AR augmented reality, MR mixed reality, and the metaverse. XR extended reality is the umbrella term that covers immersive technology. The representative forms such as VR, AR, MR refer to all real and virtual combined environments and human-machine interactions generated by computer technology and wearables. Virtual reality is immersing yourself in a completely artificial world. Augmented reality overlays a digital layer of contextual information into the built environment. Mixed reality is an interactive mix of VR and AR.
Extended reality technologies have enabled intraoperative access to patient-specific 3-dimensional anatomy. However, their clinical effectiveness is fundamentally constrained by spatial coherence, defined as a perceptual consistency between the real surgical workflow and virtual anatomical information. Spatial coherence is jointly influenced by tracking uncertainty and motion to photon latency, which surgeons may perceive as migration, jitter, or delayed visual follow-up during head movement. System development. We developed an AI-integrated XR surgical support method using a video pass-through head-mount display designed to reinforce spatial coherence during robotic, hepatic, and pancreatic surgery. AI anatomical modeling. Patient-specific 3-dimensional anatomical models were generated from preoperative contrast-enhanced computed tomography using deep learning-based automated segmentation. These models included liver segments, segmental and subsegmental Grisonian pellicles, hepatic vein, portal venous branches, bile duct, pancreatic parenchyma, and SMV branches. The AI-derived anatomical presentations were integrated into a BPT-based XR environment and introduced intraoperatively as a reference during robotic procedures.
So we developed the web-based XR application like a car GPS navigation. From CT and MRI images, organs and lesions are extracted into colored 3D polygons. We represented it into virtual and real space using our original web-based XR application named Holo Eyes. And we already got a Class 2 medical device certification in Japan. And we have integrated a commercially available cloud service that accomplishes XR in only 5 minutes. When you upload your patient data to our server, after 5 minutes, you can see these data in the air. So we already certified as a medical device in Japan. We are now integrating these kind of technologies like XR, extended reality, VR, AR, and MR. So nowadays, we can use the Meta Quest goggle. It can transparent the actual environment with a VR goggle, like video pass-through. So nowadays, the Apple Vision Pro is also available for our application. Our Horizon MD application is only one medical device for a program in Apple Vision Pro in the world. When you wear the Apple Vision Pro during the surgery, you can grasp the patient data in the air, even with the sterilized glove on the patient. In the near future, when you perform the endoscopic surgery, you don't need to watch the monitor, but the VR goggles. We can share this 3D perception between several surgeons wearing the goggles. It's also available for integrating the Type Pro for Da Vinci. We integrate the endoscopic 3D data to Vision Pro. And this is a single port Da Vinci. It's also available for reduced endoscopic port. Actually, the right monitor is virtual. The left is real. So you can move the virtual monitor any place you want in front of the patient. And you can change the size, and you can augment the patient CAT scan data. In Japan, we have two Japanese robotic surgical devices. This is Saloa. We are now integrating endoscopic 3D data to Vision Pro.
During surgeries, surgeons use an XR headset with binocular transparent glasses, enabling them to see the patient's anatomy as 3D holograms, fully integrated into their surgical view. We evaluated this system across 20 endoscopic and robotic HPB surgeries. Our system accurately replicated organs and lesions as 3D holograms from preoperative imaging, clearly defining surgical resection lines and identifying potential risk areas. Notably, in robotic-assisted liver resections, it facilitated understanding the spatial relationships between liver veins, portal veins, and resection planes. In robotic-assisted pancreatic otodenectomies, it proved instrumental in preventing bleeding by delineating the arterial structures around the pancreatic head and posterior pancreatic surfaces. The system's precision was within a 1.2 mm range, leading to decreased operation times and minimal blood loss. All cases resulted in cancer-free resection margins. Its integration with the metaverse opens up innovative applications like virtual conferences for interactive discussions and training sessions. Spatial computing in endoscopic surgery. A groundbreaking aspect is the application of spatial computing in endoscopic surgery. Discussion. This system is a revolutionary surgical tool and an educational asset. Certified as a medical device in Japan, it is at the forefront of telemedicine. Its integration with the metaverse opens up innovative applications like virtual conferences for interactive discussions and training sessions. Recording the movements of surgeons' hands or robotic arms in the XR environment creates a metaverse repository of surgical maneuvers. This method unravels the implicit knowledge in endoscopic surgery, enhancing spatial understanding and procedural familiarity. Revisiting these recordings in XR space offers invaluable insights and training opportunities, potentially revolutionizing surgical education and practice. This was also useful for recording surgical procedures in VR space, and for handing down surgical skills to the next generation. Our cross-platform XR collaboration app enabled holographic telepresence through augmented reality, turning any operation rooms into a 3D workspace. With our system, users connect remotely and express ideas seamlessly using avatars, unlocking a new level of computing that is not confined by space, no matter what device they are using. Recently, this virtual shared space is called Metaverse and is increasingly used in the surgical field as an alternative to the real world with its superior physicality, spatiality, immersion, and interactivity. This medical practice with the coexistence of presence makes it easier to record and experience the techniques of skilled practitioners as physical movements in the XR space, which significantly increases the efficiency of practice and contributes to the formalization of tacit medical knowledge, which is nonverbal information. These technologies has already been used in many medical facilities for surgical planning, simulation, treatment support, medical education, and training to improve techniques and avoid misidentification.
So this is, I think, very green transformation. And we can reduce energy consumption and CO2 emission and the cost using the VR goggles without the huge monitor. And actually, comparing to a large LCD display, we could reduce the power consumption and the cost and the CO2 emission.
The reasons why VR technology can make endoscopic surgery greener are as follows. 1. Reduced energy consumption. 2. Minimized physical resource usage. 3. Decreased manufacturing and disposal. 1. Reduced energy consumption. VR headsets employ two small, magnified lenses placed close to the eyes, creating an immersive viewing experience while using compact displays. This design significantly improves energy efficiency compared to large 2D monitors, which require more power to operate. 2. Minimized physical resource usage. VR technology can greatly reduce the need for physical equipment in the operating room, leading to decreased electricity usage. Additionally, it minimizes the physical movement of surgeons and equipment, which in turn helps lower CO2 emissions. Replacing physical resources with virtual data further reduces the consumption of medical supplies. 3. Decreased manufacturing and disposal impact. The manufacturing and disposal of traditional 2D displays are resource-intensive and energy-consuming. In contrast, VR headsets have a lower production footprint and are more cost-effective. By reducing the reliance on traditional displays, VR helps lessen the environmental impact associated with their manufacture and disposal. Traditional LCD displays, which are widely used in endoscopic surgeries, consume considerable energy. Depending on the screen size, power usage over 6 hours of daily operation ranges from approximately 120 watts for a 55-inch display to 50 watts for a 27-inch display. On the other hand, VR goggles offer a more energy-efficient alternative. For instance, the Apple Vision Pro uses just 20 watts, while the Meta Quest 3 operates at a mere 15 watts. The annual energy consumption of LCD displays is significantly higher, amounting to 131.4 kilowatt-hours for a 55-inch display and 54.8 kilowatt-hours for a 27-inch display. These figures correspond to annual costs of $50 for a 55-inch display and $20 for a 27-inch display, highlighting the substantial environmental and financial burden posed by traditional LCD monitors. In comparison, the annual energy consumption of VR goggles is much lower, with the Apple Vision Pro consuming only 21.9 kilowatt-hours and the Meta Quest 3 requiring just 16.4 kilowatt-hours. This translates to annual costs of just $4 and $3, respectively, demonstrating a significant reduction in energy demand. The comparative analysis emphasizes the energy savings achieved by switching to VR goggles. The Apple Vision Pro reduces energy consumption by approximately 83% compared to a 55-inch LCD display, while the Meta Quest 3 achieves an approximate reduction of 87%. Similarly, the transition to VR goggles significantly decreases CO2 emissions, leading to annual reductions of approximately 54.8 kilograms of CO2 with the Apple Vision Pro and 57.5 kilograms with the Meta Quest 3, which significantly contributes to lowering the carbon footprint of operating rooms. Furthermore, this shift reduces the need for manufacturing and disposing of large monitors, promoting a circular economy. By adopting VR goggles in operating rooms, healthcare facilities can significantly reduce energy consumption, lower greenhouse gas emissions, and take a meaningful step toward greener and more sustainable practices.
Nowadays, we developing the new technology using AI and machine learning for spatial object tracking. By using this spatial object tracking function, we can copy and paste the 3D object in the air, and we can merge the CT data to actual location of the organs. This is an example for a liver. So when you open the patient abdomen, you can watch the inner space of the liver on the liver surface. So when you move, the data will follow at the same direction. When you grasp the liver, the data will follow without the marker. Usually, the AR marker should be needed to put on the actual object, but the Apple Vision Pro can capture the shape of the organs from any directions. So markerless registration can be done under our original application. So we have developed a new function. Vision Pro's extra cameras use spatial object tracking and machine learning to recognize the organ in surgical field that matches a pre-trained 3D organ model.
Tracking and latency. The system combined internal measurement units, depth sensing, and multi-camera inside-out tracking to achieve stable 6 degrees of freedom pose estimation. In parallel, the MTP latency budget from sensing and tracking to rendering and display was explicitly managed to preserve perceptual alignment between head motion and visual updates. Key clinical value. The AI-integrated XR method was most valuable in 3 standardized surgical phases. A final confirmation of hepatic transection lines prior to initiation of the Plingle maneuver, branching confirmation during Grissonian pedicle first approaches, and pre-dissection assignment of SMB branch anatomy before vascular handling. Surgeon reported enhanced spatial continuity between expected and observed anatomy even during dynamic head movements. Conclusions. An AI-integrated XR surgical support method using a BPT head-mount display can strengthen spatial coherence in robotic hepatic and pancreatic surgery by tightly complying deep learning-derived patient-specific anatomical intelligence with latency-aware tracking stable visualization. This approach functions as a cognitive scaffold during high-risk surgical phases and warrants further outcome-oriented prospective evaluation.
The infinite cognitivity in emerging as an alternative to the physical world, replicating its sense of presence, space, interactivity, and immersion, and enabling everyone to act as if they were truly here. This is my take-home message to experienced surgeons. So surgical navigation enhances, not replaces, expert skill. In the AR era, surgery combines experience with digital and spatial intelligence. Experienced surgeons should lead this evolution. To young surgeons, please use technology not passively, but as a tool for clinical decision-making. The future of surgery belongs to those who blend hands-on skills with digital insight. So this is not nice to have. This is must have. We would like to empower surgeons to optimize medicine. Thank you for attention.